and we are going live discussing capsular contracture. We do this every week. We go over different topics in plastic surgery, and I get to answer your questions. A lot of questions this week, so I'm super excited about that. So why capsular contracture? Because I've been getting a lot of questions about this, and this is a topic that it's a little bit complex. So I'll try, and you see this busy board, I usually have like 3 things written here. It's busy because it's a lot, but I'll try to explain it as simple as I can, and then we'll jump into some questions, okay? So what is capsular contracture? It's a possibility after any breast implant procedure. So after we put an implant in our body, the body creates a capsule, which is a scar tissue around the implant. That is normal. Everybody develops that capsule. And it's actually not only breast implants. Any foreign body that we put in our bodies creates this capsule and scar tissue around it. For example, a hip replacement, knee replacement, anything, right? Our body creates that capsule around it. And for breast implants, it's actually good in a sense because it kind of creates that that space where the implant sits. And if we create a good tight capsule, in the sense that it's around the implant, it's soft and pliable, it actually keeps the implant where we want it. So it's actually, the capsule is our friend, but sometimes our body creates a more thickened capsule and it becomes painful or deforms the breast. And that's when we put the term capsular contracture. So capsular contracture, it comes in 4 grades. Grade 1 is a very mild form of capsular contracture. Majority of patients don't notice any difference in the shape of the breast or the feel of the breast. On a grade 2 is when we start noticing some basic changes. And a lot of patients say, oh, it's painful. Actually, for a capsule to become painful is a grade 4. Usually, initially, it's not a pain, it's that you're gonna see that it's a little bit higher than the other one. And when you touch it, you feel that it's a little bit firmer or harder than the other breast, okay? So this is what you're gonna start feeling, a little firmer. At the first few weeks, nobody can tell if it's capsular contracture or swelling, okay? So I don't want every patient with an implant to be stressing about possibility of capsular contracture because initially, those first 3 months, all breasts are going to feel a little bit hard. They are going to feel a little bit harder or asymmetric or higher. So we have to wait and have your body settle the implants in. What things you can do in that early post-op period, if you're feeling that one, it's feeling off. I have a lot of patients that tell me that have capsular contracture that we know that it progressed and it's like, yeah, this is capsular contracture. A lot of them tell me, I felt that side just different from the beginning. It felt a little bit more painful. It felt a little bit, I felt it more than the other side. The other side was completely unnoticeable, and that side, I felt it more. So there are some things that you may be feeling, but you may be feeling that also in the post-op period. So what we can do in that early post-op period while the implants settle, after 2 weeks from surgery, you can start massaging it, okay? The massages are basically to kind of stretch that capsule a little bit so the capsule forms. We want the capsule stabilizing the implant but not squeezing it, not pressuring it, okay? So we want to move the implant a little bit from side to side, top to bottom, corners, without putting too much tension one side or the other because we don't want that capsule to be too big. If we have a too big capsule, that's when a lot of patients say, when I lay down implants go to the sides, that's because the capsule is too big and it moves around, okay? We don't want that. But we want the capsule to basically be holding the implant, not pressuring on it. So this slight movement of side to side, up and down, and 45 degrees on each side are helpful. And after 2 weeks from surgery, every patient can do it. If you had a breast lift with the implant and you have wound openings, I don't recommend you start massaging it because I want that wound to heal, okay? So that would be the only exception, okay? So grade 2 looks normal, just feels a little bit firmer. Grade 3, it's when it starts to look different. So it starts to look a little higher, tighter than the other breast. And then grade 4 is the most severe form of capsular contracture. The breast looks completely asymmetric, it's hard, and it's painful, okay? So what are the risk factors? How can we avoid this, right? How do we know if I'm gonna get it? It's the common question I get. The bottom line is that it's multifactorial, which means that a bunch of things are contributing. So we're gonna try to minimize all of the risks, but it's never zero, okay? So we're gonna minimize all of these things that I put here as much as we can, but it's never zero, so we have to be aware of this as a possible complication to target it and be able to treat it early on, okay? So the number one and most common or most studied factor is bacterial contamination. And I say contamination instead of infection because breast infections are fairly rare, especially if you're going to a center that has a very good infection protocols and follow their patients very well. My infection rate of breast is extremely low, okay? So, and I have capsular contracture, right? And capsular contracture rate will still be there. Depending on the implant, it ranges from around 0.6% to 2%, more or less, okay? So if I do 100 breasts a year, 2 breasts are gonna have capsular contracture, or 1, okay? So it's always gonna be there, but we try to minimize the infection or contamination of bacteria as much as possible. Why? Bacteria contaminating the area without enough number to cause an infection may cause just an inflammatory response in your body that creates that capsule figure, okay? So what are the things that we do to minimize that bacterial contamination as much as possible? Antibiotic use is the first one. I'm gonna put you in IV antibiotics before induction of anesthesia, and then you're gonna go home with PO antibiotics. I'm gonna wash everything in surgery with antibiotic solution and betadine solution, not only the implant. After I open it sterile, I'm gonna irrigate it with that, but also the pocket where the implant is gonna go. I use what is called the no-touch technique, so no one is touching the implant, okay? And you're like, what, are you a magician? You just close your eyes and the implant's in? No, I use what's called a Keller funnel. Keller funnel is a plastic funnel, basically, that the implant goes directly from the sterile container. I irrigate it with betadine and antibiotic. It goes directly on this funnel that is completely sterile. I put some retractors and I push the implant in. So the implant goes from their sterile compartment to the pocket that has been irrigated without no one touching it, because even I'm with gloves that are sterile. I clean everything sterile. Everything is sterile. There's always some amount of bacterial contamination that is microscopic and not enough to cause an infection, but it could potentially increase the risk of the capsular contracture. Implant rupture is the other one. Also sterility-wise, a lot of things that we do here at Pure to minimize bacterial contamination in the operating room. Of course, we're JACO certified, so our sterilization techniques and protocols are up to par of hospitals. We use UV light before you go into the room. No one that it's not in the case. So the minimal amount of people in the operating room, just the hands and bodies that are needed. You know, anesthesia, me, my surgical assistant, and my circulator. That's it in the operating room. So all of that contributes to minimizing that bacterial contamination. Okay. Implant rupture is another risk. Of course, if the implant ruptures, your body is going to detect something abnormal. It's going to create that response of your body that can thicken the capsule. Hematoma or seroma formation. This is again very rare, but it's the main reason why, if you have a hematoma early post-op period, and the reason why I ask for post-op one-day pictures or to see the person is to make sure there's no bleeding or no increase in size on one side or the other. Because if you have a hematoma, we have to bring you back to the operating room, get rid of that old blood, clean everything up, and put the implant. Because if we don't, then the body's gonna try to get rid of this hematoma. And guess what the body does to get rid of the hematoma? Inflammation. So that's gonna create a capsular contraction later on, okay? The other one is genetics. So this one, we can't do much, okay? Genetics means how your body heals. So if you're prone to hypertrophic scars or keloids, you have an increased risk of capsular contracture because your body's gonna heal more, basically. Your body creates an abnormal increased response to healing. That's basically a hypertrophic scar or a keloid. So your risk of capsular contracture is higher. So something to consider if that's the case, okay? The other one is where and how we place the implants, okay? So the incision we choose, the placement of the implant, so what plane we put the implant on contributes to increasing the risk. So where, if we're doing just a straight breast augmentation, the least risky incision is the fold. It's the INF or inframammary fold incision. If we go through the nipple, if we go through the armpit, increased bacteria colonization in those areas, so it increases the risk of capsular contracture. That is why my preferred approach for breast augmentation is the fold, okay? And not only the incision, but where do we place it? So there are really three places where we can put the implant. One is subglandular or under the gland that has the highest rate of capsular contracture. We have under the muscle or submuscular, historically, that this one is the one that has less risk of capsular contracture. So this one is the one I usually use when I'm doing breast lifts to have an extra layer of protection on the implant. But there's a new approach that I've been using for a couple of years now, and it's becoming more popular around the surgeons, not only in the United States. I just came from a congress in Austin, Texas about aesthetic surgery, and that it's not only in the United States, it's worldwide. Europe, Australia, London, everybody is agreeing that this placement is actually very beneficial and has been shown to also have a decreased rate of capsular contracture, is the subfascial plane. So it's the muscle has a fascia that's covering the muscle, and it's basically elevating that cover that has that support, but not touching the muscle underneath and putting the implant right there. So I do this approach to a lot of my breast augmentation procedures, and I've seen great results, and it has a decreased risk of capsular contracture. The higher is the subglandular, and that's why I don't do this approach, okay? The implant surface itself also plays a role. We have historically two implant surfaces, a textured and a smooth. Now with the new company called Multiva, we have a third classification of implants. Willie is dancing behind the phones, and
I'm giving instructions.
Oh my God. I really need to put a phone on filming Willie. Okay, so there is a third classification of implant surface, which is the Multiva micro or nano textured that has just so historically we have the textured ones. Those are 80 to 100 microns in roughness. Then we have the smooth, which is the ones that I regularly use. Those ones don't have an association with lymphoma like the textured one does, and that's why I don't use textured. Actually, textured has a decreased risk of capsular contracture, but an increased risk of lymphoma. I'll take the capsular contracture over the lymphoma, so we're staying with the smooth, right? But now Multiva has developed this new capsule or shell of the implant that has nano textured, so it's only 4 microns, so it has been proven to not be as inflammatory as the textured, so no risk, and it's been used in Europe for 14 years without any cases of lymphoma. So we can extrapolate that data to the United States saying that it's safe, but also it increases or decreases the inflammatory response of the body and has decreased risk of capsular contracture. So it is something to consider if you are trying to do everything to decrease the risk. These implants have been shown to have a decreased capsular contraction rate than the smooth implants. Again, both are very low rate of capsular contractures, right? We're talking about 0.6% versus 1.2%, very low. But if you're really trying everything that you can, that's another thing of the multifactorial things that I'm mentioning that you can consider. And the last one is poor blood supply. This is there. I don't do radiation patients, and this is the main reason. Patients like, for example, that had breast cancer, had radiation to the breast, or lung cancer and radiation to the breast have a very high risk of capsular contracture because the blood supply of the skin has been affected. And that is why if you're a smoker, I'm going to ask you to stop smoking for a month before surgery and a month after surgery, because the smoking just decreases the blood supply and increases your risk of having capsular contraction, okay? So we did all of this and you still develop capsular contracture. What can we do? So basically we have non-operative options and operative options. Of course, non-operative options would be to the lower gradings that will respond and improve. If you are at a grade 4 that it's already painful, distorted, then we're at the level that you need surgery. But if you're in a grade 2, grade 3, still not deformed, just a little bit firmer, we can start with massages and Montelukast. Massages, like I explained, right? You try to do this as much as possible, minimum of twice a day, in the morning and then at night, for at least 3 months. This is something that's not going to change overnight, okay? You're not going to do 2 massages and then, oh, it's softer. No, it's going to take time, okay? And most of the time I ask for pictures, because even like you're massaging the breast every day for 3 months, you're basically not noticing much of a difference, and then you take the pictures, you compare them, and you say, oh my god, look, the implant was high here, and now it's getting softer, it's getting lower, you can see it in the picture. So that's always a good thing to do, to compare how the progress is going, okay? And Montelukast is singular, and you're like, Dr. P, are you nuts? Like, that's an allergy medication. What are you using? And it's funny, I've gotten this from primary care physicians emailing me and writing letters to say, what is wrong with you? That is an allergy medication, why am I going to give it? Well, allergy medication, basically what it does, it decreases inflammation in your body, right? And allergy is an increased and inflammatory response to allergens, like stuff from out the outside. So it has been shown to improve capsular contracture, okay? So Montelukast is something, at least 3 months of usage, at 3 to 6 months to see a difference. What it does in the majority of time is stops the progression of it, okay? So if you're in a grade 2, some people go down to a grade 1, the majority of patients don't progress to a grade 3 or 4, okay? And at that point, it's your decision, how much this little difference in, when you're grade 2, right? This little difference in firmer and softer bothers you, that you want to get it fixed, or you are okay with that. Of course, if we're in a grade 3 to 4 that you see an asymmetry, then the best thing to do is to have surgery. And what is surgery? We have to remove the entire capsule, so it's capsulectomy, and we have to change the implant. And most of the time we have to change the plane. Remember that I talked here where we put the implant? Then most of the time we change the plane. We have to create a new pocket for that implant to kind of restore and reset the inflammatory response of our body to that new implant, okay? The implant companies have warranties that cover part of the surgical cost and also the implant. For the implant exchange. So it's a process, right? You have to submit a claim, but most of the time we do work a lot with Allergan, and they're great in that process to help you in the process of surgery, okay? And once that we did surgery, we did the capsulectomy, implant exchange, change the plane if it's possible, I'm going to put you in Montelukast for at least 6 months, okay, to try to decrease the rate of recurrence. And also I'm going to ask you to start massages 2 weeks after surgery, more diligent than before, okay? So we're going to be more diligent with the Montelukast massages and doing all the surgery to try to decrease the recurrence rate, okay? Let's get some questions now after I blurred all this information and everybody's confused.
Let's start with reminding you BMI. She asked, BMI of 40, can I still have surgery?
So BMI of 40, it has associated risks that are too high, okay? And what are the risks? Infection, wound healing problems, problems with pulmonary embolism or clots from your legs that travel to your lungs. So my BMI limit is 33.5. But I do encourage everyone to get as close or lower than 30, because that's when the majority of the risk factors definitely drop to negligent.
Okay. Those lymphatic massages of breast helps prevent capsular contracture.
So it's not a lymphatic drainage massage like for what we do for liposuction, but the massages, like I mentioned, do help. So, but you don't start it early on, like with the lymphatic drainage massages from liposuction. You do start in 2 weeks after surgery, okay? And then, like I mentioned, you want to move the implant from side to side, top to down, and on the corners to try to create that capsule that is snug but not too tight on the implant.
Can the capsule be revised and fixed if it's too big after they have settled?
Very, very good question, and yes. So the capsule, like I mentioned at the beginning, is our friend. It's actually the tissue that forms, that is supporting and taking and making the implant stay where we want it. But sometimes if the capsule stretched, we can do what's called a capsulorrhaphy, which is putting sutures on the inside to make that capsule smaller. Or we can actually do a partial capsulectomy, remove part of it and suture it back to try to tighten that capsule and make the breast look tighter instead of being more to the armpits or to the lower side of the chest.
Okay, also, if you have thin skin, do you recommend a lift without implant for healing purposes first and then the breast augmentation?
So, I mean, that is an approach, definitely. Depends on how thin you're mentioning. I usually combine it. I do a fair amount of massive weight loss patients if they have very thin skin. What I recommend is to put a small implant. So if we are going to do a breast lift on a very thin patient, I may just say let's put just a small implant to add volume but not add too much tension and pressure on the incisions, or a surgical bra, a mesh, which is put on the inside to support that implant and not have that tension on the skin directly.
If someone tends to develop keloid scars, it can increase the risk of capsular contracture.
Yeah,
Yani.
unfortunately, that's the genetics component of it. It doesn't mean that every single patient that has a history of keloids will develop a capsular contracture. Like if you have history of keloids, you may have noticed, I don't know if that's the case, that you have keloids in some areas of your body, but not in every scar or in every wound that you have in your body. And that's very common. There are areas in our body that are more prone to keloiding, and that has to do with the thickness of the skin and the tension where the scar is placed. For example, the earlobes and the ear are an area prone to keloids, the chest, the back. So those areas are more prone to keloid. I have a lot of patients that develop keloids in the fold incision, but not in the nipples. And that's because the chest skin is different than the breast and nipple skin. So I say all of this to say it's not that if you have keloids you will have capsular contracture, it's that your risk is a little higher. Okay, thank you so much, you guys. I know this was like a tough topic to try to explain in a way that it doesn't like bombard you with a lot of information, but my goal was to explain it in a way that you can see that it's not one thing, it's multiple things, and unfortunately we can't just say you're gonna get it and you're not, and if you had it, oh, if we do this it's gonna get fixed and that's it. But we try to minimize all of the risks that we have to try to decrease the risk of recurrence or of happening in the first place. Okay, if you have questions about this or anything, you can always DM me. I'll gladly do another live about it or answer it in the stories. And thank you for joining. I'll see you guys next Tuesday on Tuesday Tips.
Thank you.